Guys, Dr. Ash here with another video, and this one is actually going to be on brain attack, also known as stroke. So this is going to be super quick, nothing too crazy, nothing too detailed. You know how I am, down and dirty. Here we go, down and dirty with the ICU nurse. So brain attack. So also known as stroke, kind of the new terminology happens to be brain attack. So don't be surprised if you see one or both interpretations of what is now a stroke. But this is a sudden focal neurological deficit. If we want to be super duper fancy, basically what happens is we have some sort of insult to the brain, which we're going to get to. One of the biggest things that happens, though, is after a stroke, it's not the end of things. And so that's where it gets really scary, because what we end up having is swelling in the brain, congestion where everything's kind of backed up, depending on the type of stroke you are going to have, which again, we're going to follow up on here in just a minute. And then vasospasm, which is basically where the vessels are just in shock about what's happening. And so they start to spaz out or contract and relax. And so that tends to cause excess damage even after the stroke. So you have to be careful with those things. Diagnosis is usually through a CT scan, and it has to be done within about 3 hours of symptom onset. So the very moment that the symptoms begin, that's when we need to start having those conversations about being seen in the emergency department or getting further testing so we can determine what kind of stroke it is, because you may hear the terminology time is brain. And so basically what it means is once we hit the anoxia without oxygen for greater than 10 minutes, it then turns into permanent damage because our nerve cells tend to not want to regenerate very easily. So we have a couple of different stroke types. Our two main types is going to be ischemic and hemorrhagic. The ischemic stroke is exactly how it sounds. There is some sort of blockage, whether it's a thrombus, like a blood clot, or an embolism, like air or fat or whatever kind of different embolism that might have, that leads to a decreased blood flow. So we can't get perfusion to the area because there's a blockage in a certain artery or certain vessel. And so basically a thrombus is usually progressive symptoms over time. So this patient tends to have, feeling just a little bit off, and then I feel a little more off, and then the next day we have full-blown symptoms. So very progressive. Whereas an embolus, like an air or fat embolism, it tends to be a very sudden onset, much like a pulmonary embolism, right? When a patient suffers a pulmonary embolism, they have a sudden onset of shortness or shortness of breath or dyspnea. And so the stroke is the same way. Hemorrhagic is also a very sudden onset, but it is a rupture of a blood vessel. So instead of a blockage, we actually have the opposite. We have a weak area in the blood vessel, usually because the blood pressure is so high, and those little vessels, they're super sensitive, and so that high blood pressure will actually cause an intracerebral hemorrhage. Bleeding can be very widespread. Therefore, even though this onset is very sudden, the symptoms tend to become very worse. They tend to become worse over several hours. So we have a couple of different risk factors for stroke, and those happen to be atherosclerosis, hypertension. I'm on anticoagulation therapy, right? I go bleeding too much, diabetes mellitus, stress, obesity, and believe it or not, oral contraceptives. General assessment findings. So these are things that I can see no matter what type of stroke I have, no matter what location I have. These are all pretty general over the next two slides that may or may not happen in a stroke. So first one we have is agnosia. Agnosia is basically, I can't remember things that are familiar to me. So if my husband walked in, I wouldn't be able to recognize him. If my dog, everybody knows I love good old Rizzo. If my dog comes in, I wouldn't be able to recognize him. Apraxia would be the inability to perform a certain movement. Like I consciously may want to move my leg, but I'm unable to do so. Hymenopsia would be blindness in half of my vision field, either left or right. Neglect syndrome just means if I have a paralyzed side, I'm completely oblivious, like I have no idea, I'm unaware of the paralyzed side. And then we have something called proprioception, which I believe you guys have heard before, but this is basically where I don't have a sense of my true body position. So again, very general things. We're going to go over one more slide of general findings. Patients tend to be hypertensive. They complain of a severe headache or lots of pressure in the head, nausea, vomiting. You may see facial drooping. I tell people in physical assessment, anytime you have two of something, two eyes, two ears, two arms, two legs, you assess for equality and symmetry on both sides. And so when one side of the face is drooping and the other side of the face is where it's supposed to be, that can tend to be stroke-like symptoms. Ataxia, dysarthria, dysphagia, so difficulty speaking, difficulty swallowing, decreased sensation, and of course, paralysis. Now, let's very briefly talk about some other side-specific symptoms. So in other words, the right side of my brain gives me a set of symptoms, and the left side of my brain tends to give me a set of symptoms. Now, generally speaking, the right side of the brain will cause left-sided paralysis. A left side of the brain stroke will cause right-sided paralysis. There's just a couple of more differences in left and right brain, but beyond that, I wouldn't go too crazy. Okay. Right brain, very much impulse control, whereas left brain tends to have issues with comprehension. Right side of the brain, they have a denial of illness. They don't even think anything's wrong with them. Whereas on the left side, they are fully aware of their deficits, and it actually causes a little bit of depression. Okay, so again, right side, very impulse control, short attention span. I call them almost like stroke onset ADHD. Okay, so right side of the brain denies they're even sick, impulse control, they have poor judgment, short attention spans. Left side of the brain, it's more comprehension, or my speech is impaired. I am fully aware of what's happening. The two types of speech I want you to be aware of is expressive aphasia and receptive aphasia. So expressive aphasia means I cannot communicate. I cannot express myself in the vocal word. So expressive aphasia, I cannot express how I feel. I cannot communicate. And this typically ends up being damage to the Broca's area, whereas receptive aphasia means written and spoken word, I'm confused by what you're saying, so I can't receive the message. And that's typically damage to the Wernicke's area, Wernicke's. All right, so interventions when we're in the acute phase all day long. I think, yeah, there's only 2 more slides left. So interventions in the acute phase all day long. Airway, 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 airway. I cannot stress this enough. We need to make sure they can protect their airway. We need to make sure that they stay conscious to protect their airway. We need to make sure we give oxygen to keep the saturations above 95%. Vital sign checks, neuro checks. If they're first coming into the emergency department, I want to make sure I do the NIH stroke scale, NIHSS, NIH stroke scale. If it is determined that they are having an active stroke, they then need to go to CT scan. Okay, so neurochecks, NIH stroke scale. We would also monitor ICPs, provide a quiet environment, and of course, provide a form of communication, because when we can't speak, we get frustrated, right? So we want to make sure our patients are not frustrated. Back to immediate things real quickly. I want to make sure you guys all understand there's a series of events that have to happen. I mentioned earlier that a CT scan will diagnose, and that is true, but there are some other things that need to go into play in order to make sure that that can happen. Okay. So basically they come into the emergency room. I want to assess their airway and give them oxygen. I want to make sure I do that stroke scale on them to assess whether or not they're having a stroke. I want to get them to the CT scan ASAP whenever we're concerned about a stroke. And then if indicated, we would give what's on the next page, which happens to be alteplase, tenacteplase, renacteplase, as you can notice, they all end in places, P-L-A-S-E. Those happen to be an enzyme used to break down or dissolve clots, okay? So obviously this is not our drug of choice if we have a hemorrhagic stroke. So if our patient is already bleeding, the last thing I'm going to do is give them a medicine that's going to make them bleed even more. So this is purely for our ischemic strokes, okay? So thrombolytic medicines only given with that blockage in a blood vessel, because these ACEs, these places, whatever you want to call them, are there to dissolve clots. It's used within 4 hours of a heart attack or 3 hours of an ischemic stroke. It returns blood flow back to the area. Obviously, after a heart attack, it returns blood to the heart. After an ischemic stroke, it's going to return blood back to the area of the stroke. Number one concern is bleeding. Hear me now. Bleeding is your number one concern. Okay, I've taken care of stroke patients. We've given TPA. Their neurological status changed. We take them to the CT scanner and find that they are now bleeding. They have turned from an ischemic stroke to a hemorrhagic stroke, which leads me to my last point that I want to bring up, which is this is a very potent medication. A little bit goes a long way. This requires double checks with 2 RNs. We give this on a pump only. I do not trust my hand to give this accurately enough. So by a pump only. Neuro checks are going to be every 15 to 20 minutes. We are not going to do any sort of invasive procedures once we administer it. Okay, so oftentimes when we get this admission in the ICU, they get a central line, they get an arterial line, they get a Foley catheter, they get peripheral IVs if they need them, NG tubes if they need them. Anything that's going to break the skin or break a mucous membrane has to be done before we give TPA, because what's going to happen is we're going to introduce that invasive procedure and these patients are going to bleed out. Okay, so be very, very cautious of that. And then I always like to tell you guys the antidote, because if they're having an overdose or something bad's happening, you want to make sure that you have it on hand as quickly as possible. Do I know that it's going to be tested on? I don't know that, but I do know that NCLEX loves to ask you antidotes, and for this one it's aminocaproic acid. Okay, and I hope you guys enjoyed that. That's a short, quick, down and dirty on strokes, also known as brain attacks. So hope you like it. Make sure you like, share, and comment, and I will see you guys in the next one.